discovered that the indigenous population were using this bark to treat fevers, and then they observed that, and then they start to use it, and also to ship the bark and the powder to Europe, and this was used also to treat fever cases. And this went on for quite a long time, for several centuries. But at that time, the exportation of seeds of the tree was forbidden by the Peruvian government. And so this guy, Charles Ledger, who wanted to export the cinchona tree, so the tree that from which they produce the quinine, managed with many adventure. He had many adventures. Managed to actually take out the seed out of Peru illegally, actually. And he went with these seeds to London, to the Kew Garden, and said, "Well, here I've got the seeds. Are you interested? We can produce this treatment." And they refused. Actually, they said, "No, thank you." So instead of from the British, he went to the Dutch, and the Dutch said, "Yeah, bedankt, thank you very much." And so for a long time, so the Dutch set up a plantation of a cinchona tree in Indonesia, and for a long time the Dutch had a monopoly on the production of wort quinine, so the 80% of wort quinine. So this is a very important milestone in the history of malaria. The other important milestone was the discovery of DDT in 1939, and DDT was used for indoor spraying in Italy, Venezuela, and Guyana. And this DDT, the discovery of DDT, opened the idea of the possibility of malaria eradication. And so in 1955, the World Health Assembly adopted the principle of malaria eradication. So the concept of malaria eradication was that you had the parasite reservoir, and you had the mosquito, the vector that were transmitting malaria. So the spraying, the indoor residual spraying was targeted to the vector of malaria. You spray indoor, and so if mosquito landed on the surface that was treated with insecticide, they would die. So the idea was really to interrupt transmission with the DDT, with the attack phase, and then wait until the human parasite reservoir would be cleared, because after a certain moment the parasite would be cleared, so the mosquito would not transmit malaria anymore, and then at a certain moment they would actually stop the spraying, and the mosquito would come back, but because there was no infected, there were not infected people, then malaria transmission would not restart. So unfortunately, so this was a very sort of monolithic idea, monolithic approach, and soon it became clear that this monolithic approach would not work. Actually, by the way, in Africa, the eradication program was never implemented. It was implemented only in Ethiopia, but not in other countries, because it was thought that in Africa the transmission was too intense to be interrupted. But this eradication actually did not work. It worked only for a few countries, but not in other countries. So in 1969, the World Health Organization decided to suspend the program, and basically the control of malaria became integrated in the normal health system. But so the issue is that here really that the idea of eradication with a single intervention was not really something that could work, because if you look at the malaria cycle with the human host, with the mosquito host, and also the different kind of mosquito, the different Anopheles species that transmit malaria, and also the complexity of the parasite that you have here. So you have, for example, in terms of species, Anopheles species, you have 41 dominant vector species. Each of these species has got different behavior, different requirements, and so on and so forth. It's obvious that you can't control malaria with a single intervention, with a single approach. And this is what Hackett already said in 1937. Everything about malaria is so molded by local conditions that it becomes a 1,000 epidemiological puzzle. So the message here is, well, if you want to control malaria, you have to take in account local condition and also really implement intervention that are adapted to the local context, to the local vector. But so for quite a long time after the WHO abandoned the idea or suspended, let's say, the idea of malaria eradication, the objective was really to limit the burden of malaria, to limit the number of deaths, to limit the number of cases. And this really was the idea that from the 90s up to 2008 was dominating the malaria world. But then I am sure you recognize these two people in the photo, Bill and Melinda Gates. In 2007, they said, well, why don't we go for malaria eradication? To the point that somebody say, oh, they said the E word, the eradication of malaria had become a bit of a taboo. But they, with the power, their foundation, they actually reintroduced the idea of malaria eradication. And just to make clear what we mean by eradication and elimination. So eradication is a permanent reduction to zero of the worldwide incidence of malaria as a result of time-bound deliberate efforts. So once you get eradication, you don't need intervention measure anymore, because there's no transmission anymore across the world. And this is different from malaria elimination. Elimination means reduction to zero of the incidence of malaria in a defined geographical area as a result of deliberate efforts. So in this case, for example, you still need to have measures to prevent re-establishment of transmission in the place where you have eliminated malaria, because the vector is still there, and you have maybe neighboring countries with transmission. So you may have imported malaria cases, and if you have imported malaria cases, if you have the vector, you can restart transmission and possibly have even epidemics of malaria. So the WHO, the rollback malaria, quickly jumped into the wagon, and they produced the following year this document, the Global Malaria Action Plan for a Malaria-Free World, just to try to sort of coordinate the effort towards malaria eradication again. And so also the WHO produced this global technical strategy for malaria between 2016 and 2030, which is based really on three pillars. Pillar one is to ensure universal access to malaria prevention, diagnosis, and treatment. Pillar two is to accelerate effort towards elimination and attain malaria-free status. And pillar three, transform malaria surveillance into a core intervention. So to conceive the surveillance as really an intervention to decrease malaria. Obviously, this should have been or should be based on research, and also strengthening the enabling environment, meaning that you need a very good health system to support all this effort. So, and these are the goals. You have different milestones in 2020, 2025, 2030, and these goals, these milestones are relative to the situation that you had in 2015. So basically, reduce malaria mortality globally compared to 2015, reduce malaria incidence globally compared to 2015. Also eliminate malaria from countries, so increase the number of countries that are declared malaria-free, and also in those countries prevent the reestablishment of malaria in these countries. Yeah. So and then for in terms of reducing mortality and morbidity, you can see here in 2020 at least a reduction of at least 40% compared to 2015 level. In 2025, a reduction of at least 75%, and eventually in 2030, a reduction of at least 90% compared to the 2015 level. So there have been during this period quite a lot of countries, quite a few countries, I would say, that have been declared malaria-free. This year, for example, in Africa, there was Cabo Verde, which is an island off the coast of West Africa. In January this year was declared malaria-free. And there are several other countries that are in a sort of what we call a sort of elimination club, if you want, in which, so these countries are in sort of in the path towards elimination. And so here you see the number of cases, these different categories, more than 1,000 cases. These are the countries, between 100 and less than 1,000 cases, then between 10 and 100 cases, and then 0 cases, and then certified. You see here the certified, there is Cabo Verde. And where is Malaysia? Malaysia is in the 0 case category, but it hasn't been declared malaria-free. Why hasn't been declared malaria-free? Because, and actually, yeah, to be declared malaria-free, you need to have at least 3 years without no case, local case of malaria. You look at there, this is a list in alphabetical order. Malaysia, you see there in 2020, 2021, 2022, you have 0 cases of human malaria. While other countries in the, if you look at the color of the numbers, if it's green, it means that it decreases compared to the previous year. If it's red, it means that it increases from the previous year. And if it's yellow, it decreases, but you know, it didn't decrease that much. Yeah. So, you know, all this, you see, it's quite interesting to see that some countries, for example, can pass from green status to red status. So it's quite variable, right? But what is the problem for Malaysia? And you have it here in the first graph. The problem is Plasmodium oelezi. So in the left axis, you have the number of all malaria cases. You see that for Malaysia, for example, in the left axis you have thousands. You know, it's in thousands, and then in the right axis the number of P. oelezi cases. So if you look at Malaysia and then Indonesia and Thailand, you see that, for example, in Indonesia, you have a few cases of oelezi, but you have hundreds of thousands of cases of all human malaria cases. The same is true for Thailand. But in Malaysia, basically, the malaria cases are represented only by the Plasmodium oelezi. And there is a simian malaria, and I think it's not clear how is going to be possible to stop transmission of this parasite. But for the time being, because of the magnitude of the problem, of the number of cases, Malaysia probably will not access to the malaria-free status for the time being. But so what we are doing, how we are doing in terms of the milestones I already presented to you. Here is a graph that is taken from the World Malaria Report in last year, 2023. The malaria report of this year is not yet out. So in blue is the actual number of the incidence, the actual incidence of malaria across the world, and in green is the incidence that how it should be if we want to achieve the milestone that have been set up. And you can see that we are quite far from the desired objective, because here you see it from starting from 2015 to 2016, there's been a sort of stalling of the number of cases. So basically, it hasn't changed too much. So we are off track by 55% in 2022. This is in terms of malaria cases. In terms of malaria mortality, you have the same kind of picture. And you see that the blue line is very far from the green line. The green line is the line where we should be if we want to reach the milestones set up by the technical document. So we are off track also in terms of mortality by 50%. And so when you look at the malaria death by countries, you have basically a few countries that represent most of the burden of malaria. For example, nearly half of deaths occur only in 3 countries: Nigeria, Democratic Republic of Congo, and Tanzania. And for that reason, the WHO launched this initiative, High Burden to High Impact approach. For these countries, there are 10 countries, African countries, plus India, that are part of this approach. And this approach have really 3 columns. The political will, try to sort of stimulate the political will in these countries. Surveillance, so strategic information, better surveillance to better target intervention, better guidance from WHO, and also coordinated response. And all this based on an effective health system. This is one of the issue probably in this country. So the health system is quite weak, and also a multi-sectoral response. So not limit the malaria, the activity against malaria only on the health sector, but involve other sectors. So that, yeah. So we are also in a changing world. We have urbanization, we have new epidemics, the pandemics of COVID, for example, the climate change, for example, for Africa, one of the risks is the invasion of Asian vector, malaria vector, Anopheles stephensi, that is very well adapted to urban setting, which risk to make the problem of malaria worse in Africa. And also the funds available that actually we will see are not, the funding that is needed for the malaria elimination eradication are not there yet. So the urbanization is a major factor for malaria, is a major challenge, because if you look at this is the projection of the percentage of urban population by region and sub-region. Here I put the Gambia, West Africa, and Africa. Here in blue, the blue line is Africa, and the green line is Western Africa, and the red line is Gambia. And if you look at that, in 2015, more than 70% of the population of the Gambia is going to be urbanized. So, which is, from the point of view of malaria, is a good news and bad news at the same time. It's good news because usually, but not always, usually transmission of malaria in urban setting is much lower than in rural setting. But at the same time, you have also the risk, as I mentioned, of Anopheles stephensi, for example. And then if Anopheles stephensi get established, it may actually start substantial transmission in urban setting. The other issue, again, this is really for Africa. The access of healthcare or the health system is quite weak. This is some data on the access to healthcare in sub-Saharan Africa. 33% of febrile children in sub-Saharan Africa do not have access to care, and of those that do seek care, 69% use public health facility, 38% use private sector at cost, and 1% use community health workers. So there are some countries, there are community health workers at the village level who are trained to diagnose and treat malaria. But the issue of malaria is also that it's a disease of poverty, and so it's the poorest section of the population who are much more at risk of getting sick, of also dying of malaria compared to those who are better off. So indeed, children in the poorest household are 5 times more likely to be infected with malaria and 2 times less likely to access care. So this is a problem. In terms of quality of services, this refers to a preventive intervention, which is intermittent preventive treatment during pregnancy. So pregnant women are supposed to attend antenatal clinic, and in Africa, in malaria endemic country, they receive what is called intermittent preventive treatment. So a treatment with sulfadoxine pyrimethamine to prevent malaria. And WHO recommend that pregnant women in Africa should take at least 3 doses of sulfadoxine pyrimethamine during pregnancy. So the issue here is that you see there are several, 57% of pregnant women visit antenatal clinic at least 4 times, 19% less than 4 visits, and 24% they don't visit antenatal clinic, but only 70% of women receive the recommended 3 doses of sulfadoxine pyrimethamine. So there is a problem there in the sense that women go to the antenatal clinic, but they don't receive the recommended treatment, preventive treatment. For the intervention, insecticide nets are really an essential intervention for the control of malaria. And there are problems related to the bed nets. So sometimes there is insufficient access. The nets are not always used. They are not very durable. They are destroyed. There is also insecticide resistance. Also, vectors may change behavior. So usually the malaria vector, at least in Africa, we say that they are biting indoor and rest indoor. But there are other vectors that can bite outdoors and also rest outdoors. So if the vector change behavior, rather bite people outside, they actually escape the bed nets, or even the indoor residual spray, the DDT, or nowadays we don't use the DDT anymore, but other insecticide. And so also I mentioned the funding gap because it has been estimated that we need at least $7.3 billion per year, and we have available for malaria control a bit less than half. So how this funding gap is going to be filled, nobody really knows. So it's a problem, and also national malaria control programs have to choose what to do, so they don't have enough resources to really attack malaria and try to interrupt transmission. So I'm going to mention 4 biological threats that really can really upset all our effort to control malaria, to go towards a malaria-free world. These are 4: vector insecticide resistance, invasive vector species, anti-malaria drug resistance, and also the gene deletion of the HRP2 gene. So in terms of insecticide resistance, this is permethrin resistance. The red one is where resistance has been described. As you see, it's pretty much across Africa. And so permethrin is the insecticide that is used for bed nets. I told you that bed nets is an essential intervention for malaria control. So you can imagine that this is a major issue. Anopheles stephensi, as I said, is an urban vector. Has been responsible for probably an epidemic of malaria in Djibouti some years ago, and is actually spreading in the Horn of Africa. It has also been described in Kenya. There is a description of Anopheles stephensi in Nigeria, and more recently in Ghana near Accra. So if this vector managed to get established in the big cities, African cities, then this can be a major problem. Also because this vector is multi-resistant to insecticide. And then the gene deletion of the histidine-rich protein 2. So the HRP2 is the antigen that the rapid diagnostic test detects. So it's the antigen produced by the parasite, and the RDT, the rapid diagnostic test, are based on the detection of this circulating antigen in the bloodstream. So there are some parasites that have this deletion and don't produce anymore this antigen. So basically, you have patients who are sick of malaria, on which you do the test, and the test is negative, despite the fact that they have a malaria. So you have basically the false negative, and is actually spreading. It has been first detected, was detected, described in Peru. And then it has been observed also in Eastern Africa, and now there are a few places in other part of the continent where it has been described. So this is potentially another major problem, because if the RDT do not detect, do not diagnose the cases, the only alternative for the time being is to do microscopy, which is more cumbersome and is going to take more time to diagnose a case. So I'm going now to talk about the other threat, which is the drug resistance in more detail. So drug resistance of malaria parasites has been defined as the ability of a parasite strain to multiply or survive in presence of concentration of a drug that normally destroy parasites on the same species or prevent their multiplication. And basically what you have is you have an emergence of resistance for some reason, then you have a delayed response, you have recrudescent infection, you have an increased gametocytes rate. This has been shown for chloroquine, for example, or sulfadoxine-pyrimethamine. Then you have an increased transmission, which means a larger reservoir, you have more clinical cases, more drug use, so you increase the drug pressure, and that drug pressure select further the resistant strain. So there is resistance to very much most of the approved drugs, antimalarial drugs. So as I mentioned, you have the de novo mutation that emerge, and then a selection of resistant strain depending on the drug pressure at which the parasite are exposed. And funny enough, most of the resistant parasites have emerged from Southeast Asia. Chloroquine, although you have emergence of chloroquine resistance also in Latin America in the 50s, chloroquine, sulfadoxine, pyrimethamine, mefloquine, and artemisinin, these are the first places where these have been, resistance to this drug has been described. And then in the case of chloroquine, for example, it has migrated to East Africa and then to West Africa. And so, just to say, the Paling in Western Cambodia is the site where the decreased artemisinin sensitivity has been detected for the first time. It's near the border of Thailand. It's an area that is quite out of control. I know that, for example, also the use of drugs there is quite anarchic, and probably that has been a factor for the selection of resistant parasites. And so what we can do today is that we have molecular markers, so mutation in the genome of the parasite that are related to the resistance, and they are pretty much markers for many of the drugs that you use. So we can actually, with these markers, looking at this mutation, we can actually do a cross-sectional survey, look how many infections are carrying this mutation. So just to say that, this is Cambodia. So the first mutation related to artemisinin resistance is the mutation in the K13 propeller allele, is C580Y. which is red in this graph, and you can see that in some area, it's the majority of the parasite carry this mutation. And really, the Southeast Asia has been the epicenter of artemisinin resistance, as you can see here. So you have Cambodia, which is the hotspot, and this has slowly spread to neighboring countries. So basically, you had a selection of the KELCH13 gene, the mutation of the KELCH13 gene, on a genomic backbone that really favor the emergence of other variants. So these variants are largely absent in Africa. However, the first description of the artemisinin partial resistance has been reported from Rwanda, and it is a de novo emergence of a mutation which you in the same gene, the PF-KELCH13, but instead of being the mutation you have in Cambodia is this mutation R561H, which this mutation provides the parasite that have this mutation, the ring form has increased survival when they are in contact with artemisinin. And you can see here the wild strain, and then you have the mutation that here in red that you find also in Cambodia, but also the mutation that you find only in Rwanda. So, and then independent from Rwanda, you have an emergence of other resistant parasite or partially resistant parasite to artemisinin in Uganda, with a totally different mutation, still in the same gene. So we have basically a lot of heterogeneity in terms of artemisinin resistance, and different mutations that confer partial resistance to artemisinin derivatives. And also, again, a different mutation in the Horn of Africa that also has emerged de novo. And so basically what you have here is that in the Horn of Africa, you have the emergence in the gene, the KELCH13 gene of the mutation R622I, which has been detected in several countries, Eritrea, Ethiopia, Sudan, and Somalia. And in Eritrea, you have the evidence of delayed clearance in the parasite that have this mutation. And the other issue is that parasite with this mutation that confers partial resistance to artemisinin some of them have also a deletion of the HRP2 gene. So that means that they have the mutation of artemisinin related to artemisinin resistance, and at the same time, they cannot be detected by rapid diagnostic test. So in Rwanda, Tanzania, you have the R561H mutation still in the same gene. And also in Uganda, again, another different mutation that is spreading as well. So it's really a difficult situation. This is a strategy to respond to antimalarial drug resistance that comprises 4 broad areas: strengthen surveillance, optimize and regulate the use of diagnostic therapeutics, react to resistance by limiting the spread of antimalarial drug resistant parasite, and then stimulate research. And each of these 4 areas have got different, I'm not going to talk about this in detail, but different activities that really try to prevent the spread of artemisinin-resistant parasite, because the artemisinin-based combination treatment are the only treatment we have nowadays against malaria. So it will be a total disaster if it becomes widespread in Africa. And so the artemisinin resistance has really been also the rationale for malaria elimination in the Greater Mekong subregion. So it is really has stimulated efforts to try to interrupt transmission in the Greater Mekong subregion. And It's coming. It's blocked. Yeah. It doesn't. No, it doesn't work. One moment. Yeah. Right. Yeah. Right. Sorry about the technical issues. Okay. Good. Yeah, it's yeah. So it's moving. So thank you very much for solving this technical issue. Yeah. Thank you for solving this technical issue so quickly. Sometimes. Yeah. So now here you see the evolution of malaria death in the Greater Mekong sub-region. So it went from several hundreds to very few, almost zero in January, August last year. So this shows really the success of the elimination effort in this region, and also thanks to that, the limitation of the issue of artemisinin resistance. And also you see here that although they haven't eliminated malaria, I mean, basically most of the malaria cases recently have been mostly Plasmodium vivax, which doesn't have a problem of resistance, while the Plasmodium falciparum here in green is really a minority of the infection. So what we can do against drug resistance? Well, we need new drugs, new treatment. We need to have an alternative to artemisinin-based combination treatment. And this is the global portfolio of antimalarial medicine. You can see there are quite a lot of drugs in the pipeline. This is from the Medicine for Malaria Venture, an organization that have been really pushed the development of new antimalarial treatments. So I just circled this one, the red one, because we are currently doing a trial on this combination M5770 plus pyronaridine, currently doing in the Gambia and Burkina Faso, Kenya, and Zambia. And so this is a phase 2 trial where asymptomatic malaria-infected individuals are randomized to one of 4 groups. There are 3 groups with a different dosage of the M5717, and a 4 group which receive Malaron, which is really the a drug that it's usually given for prophylaxis. And so these participants are treated, and then they are followed for 2 months to look at how the parasitemia, what's the treatment response to this new treatment. So the other things that we are doing, we have been involved into this study, is a trial on the efficacy, safety, and tolerability of triple artemisinin-based combination. Because the idea of the combination is that to reduce the chance of selecting resistant parasites. So if there are parasites resistant to one of the component of the combination, the other component will take care of it. In this case, because of the risk of artemisinin resistance, you can actually add a third component into the treatment, so triple artemisinin-based combination therapy, and these are basically artemether-lumefantrine plus amodiaquine. And the reason why amodiaquine is added to lumefantrine, artemether-lumefantrine, is because lumefantrine and amodiaquine has a different opposite selection pressure on the parasite, and similarly, the other treatment is artesunate mefloquine plus piperacin. So we have been doing this multi-center trial, which actually is sponsored by Oxford, by Moru, and there are different sites in Africa and in Southeast Asia. So this trial is not finished, but the results are promising. So hopefully this triple artemisinin-based combination therapy will become an option for the treatment of malaria. And I think that's all. So I've given a sort of overview of the issues from the past and what are the issues and the threats nowadays. I think the dream of a malaria-free world is still a bit far, but hopefully we should still try to pursue it and try to achieve it. Thank you very much for your attention. So this is, a postcard from the First World War. These is a soldier who did not slept under a bed net. So you see a lot of mosquito, a lot of bites, and the other one slept under bed net. So the women are very much like you. Yeah. All right. So I'm happy to take any question you may have.
Prof, we have some questions from the online participants.
Yeah.
Due to the gene deletions, does that mean BFMP is still the only screening tools with high sensitivity?
You mean the microscopy? Yeah. Well, microscopy and rapid diagnostic tests have become the standard diagnostic test. So, if rapid diagnostic tests do not work, the only alternative is microscopy. So, yes.
Okay, and then the next one. How does the treatment regimen change if a patient is found to have an artemisinin resistance rate?
Yeah, yes. So so first of all, it's very difficult to diagnose. a patient of resistant strain at patient level. So because the test is not available, you need to do a molecular test. You need to do a molecular analysis. So this is not available at the level of a clinic, hospital, and so I think if I understand the question, the issue here is really the fact that the mutation, knowing what mutations circulate, what's the prevalence of this mutation, provides an indication and information to the National Malaria Control Program and to the Ministry of Health to decide whether to change the first line treatment from one to the other. But at the individual level of the patient, I don't think we can use, at least at this moment, we cannot use we can't diagnose whether somebody is carrying an artemisinin resistant strain. Okay. Yeah. Okay. Is it possible that African parasite resist artemisinin is part of drug with additional mechanisms that are different from that to certain degree? Yeah, actually, yeah. As I mentioned, there is an emergence de novo of different mutations into the KELCH13 gene, different from what we see in the greater Mekong subregion. So, absolutely, yes. Also, we have to think that the parasites, both the parasite and the vector, are extremely plastic, and so when they are pressure, they are trying to find a way of escaping that pressure. So it is possible that they will also come up with different mechanisms for resistance. Yeah. Any chance to use RDT for PK in the future? That one I'm not sure actually. I think I'm not sure. I mean, to be honest, I don't know. I don't think the RDT we have today. I'm not sure whether the RDT we have today can be employed also for the PK, for the Plasmodium knowlesi. But yeah, it would be good to have an RDT for Plasmodium knowlesi. Then I have two questions. Just for in order for a country to be declared as malaria-free country, for example, Malaysia, is it solely based on the number of infection caused by one species or all 5 species? What is the development of malaria vaccine currently? Okay, so yes, in principle, it is based on the clinical cases due to human malaria parasites. In the case of Malaysia, it's a case which is very special because Malaysia has managed to stop transmission of human parasites, but then you have substantial transmission of Plasmodium knowlesi. And so this has been debated also at the level of WHO. It's very difficult to provide a malaria-free certificate in a country where you have thousands of cases of Plasmodium knowlesi. So in terms of vaccine, yes. So as you may know, there are 2 vaccines that are available now. RTSS produced by GSK, which had a very, very long development. And then R21, which has been developed by the University of Oxford and is now produced by the Serum Institute of India. So these vaccines have been developed for the use in children in the EPI, so the enlarged program on immunization in Africa. So they are against Plasmodium falciparum, and actually, so it's a fantastic development because the dream of a malaria vaccine is a long-standing dream that now has become reality, at least for children, African children. And then future. When should we expect a patient might have falciparum resistance? Where in Malaysia can we suspect the PK13 mutation? Well, I mean, for the so when we suspect a patient might, well, particularly in Malaysia, when you have transmission is not very high, if you have a patient that you treat and you ask the patient to come back after 14 days post-treatment, if this patient is still positive, you still have parasite in the bloodstream, then it's likely that this patient may have a resistant infection. I'm not sure where you send the samples for the PFK13 mutation. I mean, this can be done. We do it in the Gambia, for example. You need to have a molecular lab. Probably you have it here, I guess. I don't know. Yeah. Okay. I think I finished the question from the audience online. I don't know if there is any question here in the room. Yes, please.
Question.
Oh,
Actually, sorry. Based on the data that you showed earlier, some of malaria were low in Africa, for example, and starting from 2020, they actually escalated and become higher compared to before. And you mentioned maybe the introduction of a new species of mosquito. Can you expand a little bit?
Yeah. Yeah. Okay. So as I mentioned, so malaria is sort of, it's very dependent on the ecological condition. So, and you always have, variation between years. So, I mean, 1 year you may have, for example, more rain, so more breeding sites, more bacteria, and so forth. So, for the new invasive species, Anopheles stephensi, it has been shown in Djibouti that probably is responsible for an epidemic in Djibouti, but it's still not clear how this new species in Africa is going to feel is going to feel within the malaria transmission. So, for example, there have been Anopheles stephensi has been captured in Nigeria and Ghana, but for the time being, it's unclear whether they have been responsible for transmission. So I think for the time being, I mean, what is safest to say is that there may be different factors, health system factors, climate factors, rains and so on and so forth, or other factors that may explain the variation of cases. So just to say that globally, the number of cases and number of deaths has not changed much since 2015. So that's what we call as the effort has stalled, the progress has stalled. So there's been a progress from 2000 to 2015. So you see that there is a decreasing trend, but after 2015-16, the line is almost flat, and that's a problem. And this is due to the fact that the health system are weak. There may be other factors that the coverage of the interventions and so forth. Yeah.
Yeah, Prof, thank you for your sharing. I just have one question. Basically, it is a bit related to what she asked just now. If I'm not mistaken, roughly around 2020-2021, the global cases of malaria spiking at that time, which we know that time is actually the pandemic COVID-19. So my question is, does the pandemic actually disrupt the malaria services during that time, which leads to the increase of death cases, or it is related to maybe the severity of COVID-19 by those places in the area that related to this?
Yeah, definitely. The COVID-19, the pandemic disrupted the effort for malaria control. So it's partly due to that. I have to say that Africa, I mean, a lot of these estimates are estimates in a sense that are not actual counting the number of cases, right? So based on models, and so I know that a few years, 2 or 3 years ago, 2 years ago, they changed the model so that also the change of the model sort of increased the estimation of deaths, for example. But definitely COVID-19 probably caused an increase in number of deaths, yeah, due to malaria. Yeah. Yes.
So I would like to ask you
Sorry, I can't hear you.
I would like to ask about the limitation and the parasite. So as you mentioned, one of the challenges that you are facing is about the limitation of the parasite which leads to the false negatives, right? So have you ever thought about the detection of the antibody that besides the genetic materials of the parasite?
Well, the antibodies, yeah, I mean, the antibodies usually are not used for diagnosis because, you know, if you do it in Africa, for example, almost everybody is going to be positive, right? Because they are not eliminated very quickly. So it depends, but I think but you know, there are other tests that are based on other antigens like LDH, lactate dehydrogenase. You know, these are other rapid diagnostic tests. So you can use different tests, rapid diagnostic tests, instead of the one based on rich protein 2.
Any more questions?
So thank you very much for the informative and engaging talk, Prof. Umberto. So I would also like to thank the online participants and also the participants here for attending this talk. Thank you so much. We have lunch probably next to this.
Thank
Thank you
you.
so much, everyone. And also don't forget to join our talk tomorrow from 10 to 11.
All right. Thanks to you all for your attention, guys.
Not like a lot like so.
Shall I stop here? Or